So FFR in coronary angiogram, we all know all over the world it is underused, and more so in India, we don't see a lot of physiological assessment of coronaries. Probably the cost restraints, probably technical issues, and probably, we are hurried to finish up the procedures. But having said that, in India, I think the FFR or physiological assessment is more important, whatever tool you use, whether invasive or non-invasive, because you see so many patients undergoing health checkups, so many patients undergoing unnecessary CT coronary angio as well. And you come up with this lesion, which is 70-80%, and then patient goes on the cath lab table and they get a stent in. And that is where, like in those patients, especially in India, the physiology assessment is very important, because we are aware, I'm sure all of us know, that only where the mortality benefit is when the patient has an acute MI. Apart from that, any pre-vascularization, whether it's an angioplasty or CABG, this is symptom relief, unless even in the ischemia trial, the sub-study of ischemia trial showed that unless there's a significant ischemia more than 10%, then only you see benefit, otherwise not. So let me go to the slides now. So 4 things which determine physiological stenosis severity is anatomical shape and severity and shape, amount of viable myocardial tissue, collaterals, and response to the microcirculation to stenosis, which is adenosine. So what is FFR? It's a fractional flow reserve, which is the ratio of the distal mean coronary pressure to the mean aortic pressure in a stenotic vessel during maximum hyperemia. So where pressure is flow with resistance, when you use hyperemia, the resistance is taken care of. So the flow becomes equal to the pressure. And it represents a very fraction of blood flow that still has preserved despite the stenosis. So that is what the basic understanding of FFR is. We all know, and my previous 2 speakers have also commented, that FFR is so far proven to be gold standard, and everything is compared now with FFR. So why is it gold standard? Because it's a well-founded scientific basis, a lot of trials, a lot of patients involved, a lot of publications on this, validated in animal model, also validated against a non-invasive test for ischemia, stress echoes, thallium scans, highly reproducible, predicts clinical outcomes. Various trials have shown that, and mostly widely studied index. Again, we spoke a lot about microcirculation, and which is very true, which is very well presented with this diagram. So when we look at cardiac circulation, only 5% is epicardial, 95% is coronary microcirculation. And that is where we call up, silent ischemia or microvascular angina, where the coronary arteries are not very significant. So when we see the lesion, what you will be asked, isn't the angiogram enough? That is what the normal interventional cardiologist would ask for. What does the physiology add? Can I use IVUS instead? Why do I need to do physiology? So it is. So if you see this lesion, these are intermediate lesions. These are not severe lesions. Even if the patient is asymptomatic and you find the lesion is 85-90%, yet I would do a physiology assessment in an asymptomatic patient with preserved ejection fraction. Relationship between anatomy and physiology is poor. We know that. Which one we should use? Should we use IVUS or FFR? I would use an FFR, because we know angiography or anatomy is a poor predictor of symptoms very early in its history. FFR again is a maximal blood flow in the presence of stenosis divided by normal maximal blood flow, which is achieved by using an hyperemia. So studies we all know, but just revising it, FAME study, which was patient with multivessel disease, indicated with all the stenosis which were more than 50%. They were randomized into FFR-guided and angio-guided PCI. FFR was measured in all the arteries and stent only if the FFR was less than 0.8 with drug-eluting stent, or angiography-guided PCI stented in all indicated stenosis with drug-eluting stent. And there was a follow-up for 12 months. So what was the recap? And key point, there was lower MACE, which was very important, which was driven by repeat revascularization and perioperative MI and not mortality. FFR-guided PCI was proven to be more cost-effective because we were using fewer stents, less contrast, shorter procedural time, and shorter hospital stay. So it was win-win on all the corners. Again, FAME2 study showed the same. FFR guidance changed the treatment. So if you look at FR documented, fewer stenosis were compared to angiogram alone. We have documented appropriateness of intervention with FFR, fewer referrals to bypass, and cost-effective procedures. It also showed 27% of the patient did not have ischemic lesions. More patients had with just one vessel disease, and fewer patients had a functional 3-vessel disease. And if you look at the FAME 10 study of French registry, the change in treatment was quite significant by 54 to 45%. The change in treatment after the FFR. And this vast explosion of data. There's a lot of data. If you look at the PubMed papers, and if you search for PubMed FFR, and the data is used, you see lot of papers, lot of trials from DIFFER, FAME2, Dynami, and Compare Acute. So what the physiology tells us: likelihood of lesion causing ischemia, likelihood of angina benefiting from PCI. Long term, do we have a long-term data on that? Yes. Now the published is a 5-year result of FAME2 trial was published long back, which confirmed the importance of FFR-based selection. If the FFR was less than 0.8, the outcome was favorable more than 0.8, medical therapy was better, if not good. And if FFR less than 0.8, the death provided sustained benefit, the need for urgent revascularization, the rate of spontaneous myocardial infarction, symptomatic relief, and without late catch-up phenomena. So these were all benefit obtained and documented with use of FFR. So though I was not supposed to speak on IFR, but I thought I'll speak 2 to 3 slides because this is a continuation. I won't speak on RFR, but sometimes we see serial lesions. So FFR, when you're doing an FFR, you can do a gradual manual pullback and see where the jump is. But again, it's not very proven evidence clinically and evidence-based. But IFR for a serial measurement is much superior compared to FFR. And what is IFR? What evidence it supports? There's no adenosine administration, so less time and cost efficiency as well. Sometimes adenosine cannot be given to all the patient because patient develop the symptoms, they don't like those symptoms and the risk associated. So what is IFR? Is an instant wave-free ratio. It's an instantaneous pressure ratio across the stenotic during a wave-free period when a resistance is naturally constant and minimized in the cardiac cycle. So this is a wave-free period, and during that the flow is measured. So do we have any evidence behind that? Yes, there are a lot of paper recently in last 4 to 5 years on IFR compared to FFR, comparing it to FFR, and which has shown that it has a similar diagnostic accuracy to FFR, where cutoff value is 0.89 in IFR, where in FFR is 0.8. Defined flare, 2,500 patient with intermediate non-culprit lesion, randomized to FFR-guided PCI and IFR-guided PCI, and there was 30-day, 1 to 2 year and 5-year follow-up. And what it proved that less PCI in the IFR arm than the FFR arm, treatment allocation with IFR and IFR. Significantly less revascularization was based on IFR interrogation. So that was quite significant. So what did the ES guidelines showed in 2018? That when evidence of ischemia is not available, FFR or IFR are recommended to assess hemodynamic relevance of intermediate grade lesion, and it's 1A indication. In summary, IFR is an adequate adenosine free index for stenosis severity. Less than 0.89 equates to FFR less than 0.8. Have similar outcome to FFR treatment, causes less discomfort, and the procedure are shorter than FFR guided procedures. So coming back to FFR now, I thought this is, that was quite basic. I think this would be more interesting. What are the pitfalls? Because FFR, if you do haphazardly, if you're not trained, you don't know, you've not gone through the training, you might end up with false positive and false negative results. So I would cover technical issues with guiding catheter, identifying the false waveforms, how to achieve the hyperemia and anatomy and physiology. So technical issues. So it's very important your technician is well versed. The height of the pressure transducer is very important. It should be at the heart level. So if your transducer goes up or down, you'll get a false rise and a false down. So it's very important to start with the basic. Make sure your transducer is at the right level. Very important to normalization, extremely important before you advance across the lesion. Very important you normalize. Take your needle out of the guide, out of the 2E. Make sure your needle is not inside. You've given nitrates and then you normalize. The removal, again, as I said, the removal of, so many people I have seen in India, they keep the introducer in and they do the normalization, which is not right. It would, skew your measurement. So it's very important the needle introducer should be out when you're doing an FFR measurement. Guiding catheter, advantage of guiding catheter, I would also use, why not use as a diagnostic? Again, FFR, I'm surprised we don't use during diagnostic angiogram, probably again because of the cost involved. Once you do an angiogram, you think there's an intermediate lesion, you could probably do it with a 6 French diagnostic catheter as well, the FFR measurement, and prevent it patient again going on the table for an interventional cardiologist to do an FFR again. So guiding catheter are better compared to diagnostic because easier manipulation of the wire, better pressure traces, and direct access to PCR. So you can directly go and do a PCR without changing the guide. Again, ostial lesion, very important to take the guide out, hanging in the aorta, normalize in the aorta rather than in the ostium. So that's also, they are very basic but important steps. Wedging of the guide catheter, very important. You look at your dicrotic notch. If you're not getting a dicrotic notch in your LV measurement, you'll get a false result. So the guide replacement, your basic pressure tracing assessment is very important. If you're using a side holes, then stenosis would be severely overestimated. So if you're using a guide hole with guides with the side holes, then you shouldn't be using FFR. You wouldn't be able to have an accurate FFR measurement. All the data continues to support functional assessment of coronary stenosis, if not used in every case. So we have been some challenges along the way. As I said, preparation, calibration, equalization between the aorta and pressure sensor is very important. Introducer in place, measurement, look for the pressure drift, wedging when aortic pressure is inaccurately measured, whipping when the sensor hits the coronary wall, underachieved hyperemia. You have to look at the hyperemia, not look at just the 2 to 3 minutes of adenosine. You have to see whether you have achieved the hyperemia looking at your tracings. Position of the cursor is very important, and look for artifacts. So then this comment, yet, in spite of so much evidence, in spite of so much physiology, in spite of so much clinical benefit using this physiological assessment, still, does it work in ACS? There are few studies which have shown. Takes too long. If you do it very routinely, it doesn't take long. You have to just attach it, and there you go. Especially IFR. Measuring ischemia during angio might be too late, not true. It is an invasive assessment, must be done by an interventionalist, not true. Even a patient physician who just do diagnostic angiogram is very easy to do a FFR measurement by even a non-interventionalist as well. I can easily decide based on angiogram. I've been doing that for years. Again, this is an overestimated and egoistic statement, and we should go away from this.